tackle antepartum hemorrhage, and that is entirely what you know. We are going to check in basis of the definition. We are going to check the causative mechanism or the etiological factors. As well, we are going to enlighten on how we can manage each independent causative factor, like etiological factors, now one by one, in terms of management, clinical features, and so on and so forth. We're going to cover the possible ones, and then we are going to base our idea on what we're capable of. Now, the objectives of today's lesson, you can see them from your hand. We have to properly define antepartum hemorrhage. We are supposed to be able to understand the classification of antepartum hemorrhage, to enumerate the risk factors of antepartum hemorrhage, and then to efficiently diagnose the same and to adequately manage the same. So that is that, as it is elicited from what my presentation entails. So beginning from the definition, just to ask anyone who knows what is antepartum, so that can at least give us an idea. Antepartum hemorrhage, that is.
It is the bleeding that occurs in pregnant women after 28 weeks of gestation.
Where Moses, thank you for that. Where I say that this is a bleeding that occurs in women, especially the pregnant women, after attaining 28 weeks of gestation. That is correct. Yeah. So remember, during labor and the entire process of pregnancy, before even labor, during intrauterine life of the embryo, there are a lot of conditions that comes to play, both positive or negative roles. Some of them result to pathological damages to either the mother or the fetus. So again, many other factors can cause bleeding. So one of the conditions as a result of bleeding is what we refer to as antepartum hemorrhage. The word antepartum is before delivery. Then hemorrhage is just that tendency of bleeding. So from my definition on your hand, you're able to see antepartum hemorrhage is defined as bleeding from the genital tract in the second half of pregnancy. Remains a major cause of perinatal mortality and maternal morbidity in the developed world. So it can cause death of the baby in the uterus, and as well it can result to any condition or disease condition to the mother. So entire thing is that you have to know we have a bleeding, and the bleeding does not come from the mouth or any other place, but it has to come from the genital tract. When you go ahead, you see we have what we call the causes. So we have show, we have placental Praevia, we have abruptio, we have vasa Praevia, which is rare, and uterine rupture. So I want any of us, please kindly play a role. Tell us what is show, what is placental Praevia as we proceed. What do you understand by the word show? Anybody? Okay, someone can tell us what is placenta Praevia?
Placenta Praevia
Mm-hmm.
is the low-lying placenta.
The low-lying placenta. Okay, another person can try. Thank you, Moses Were. Any other person who can tell us about the abruptio placenta?
Can I check on?
Yeah, just say it, Moses. You can say even all of them once. Define them.
Okay, placenta abruptio
Mm-hmm.
is detachment of abnormally
Mm-hmm.
mutation of abnormally placed placenta
Mm-hmm.
the uterine wall.
Okay, and I'll advise you increase your volume because you are very low, very low. Yeah, so we are going to check on each of these one independently from one hand to another. Thank you, Moses Were. So at the beginning here, we are going to start with the placental Praevia, and then based on that, for the definition of placental Praevia, is that the placental Praevia is an obstetric complication that classically presents as a painless vaginal bleeding in the third trimester, secondary to an abnormal placentation near or covering the internal cervical opening. Now, I want you to know entirely that we know the endometrium and the deciduum, which is supposed to be the attachment of the placenta when it is formed, that is after implantation of the fetus. Now, the placenta is supposed to be located on the upper, next to the fundal uterus, that is in the upper endometrium. Any other place where the placenta is going to fall as a result of any condition, may be natural, but it is lower toward the cervix. That is what we call placental Praevia. The placentation is just that process of placenta formation. So it's supposed to be formed next to where the implantation takes place, on the fundus of the uterus. But anything can occur. So what we refer to as the placental Praevia is when the placenta is formed next to the internal cervix. I mean the opening, the internal or hairs of the cervix. That is very low in the uterus. Now we are going to see and we are going to classify placental Praevia in the same. So I need you to know that this one is a leading cause of third trimester hemorrhage. And when I say third trimester hemorrhage, bleeding at the third trimester. And when do third trimester start? Who can tell us when do we classify, pregnancy or gestation as in third trimester? What weeks basis or how many months basis? Any idea of when do we have third trimester, from when to when? Yeah. Okay, the third trimester is supposed to run from 29th week to 40 weeks, right? So it can be from 7, 8 to 9 months. That is that. So anything that can result, so the placental Praevia normally is the chief causative factor of bleeding, leading to bleeding at the third trimester. So the placental Praevia will present by that visibility of bleeding. So when I say it presents classically as painless bleeding, and the bleeding is thought to occur in association with the development of the lower uterine segment in the third trimester, then another thing is that placental attachment is disrupted as this area gradually thins in preparation for the onset of labor, and this leads to the bleeding at the implantation site because the uterus is unable to contract adequately and stop the flow of blood from the open vessels. So the entire thing in this content, what I want you to know, that one of the antepartum hemorrhages is placental Praevia, and this one is caused as a result of placentation taking place in the lower uterus, that is next to the internal cervical or hairs, or what we call the opening of the cervix, and then it manifests or presents with the bleeding, which is painless at start. So most commonly you realize even the mother atakuwa anajua, the pregnant woman will not even identify that there is abnormal disorder, just think like, why am I menstruating yet I'm pregnant? But yet, because it is painless, there will be bleeding. So that is that. So at most, the bleeding will start showing off when we have what we call segmentation or development of the lower uterine. That is during the third trimester. That is why the presentation is greatly there, or maybe having been noticed during the third trimester. Now let us check on the factors, etiological factors, or causative factors of what we call the placental Praevia. And placental Praevia, we are looking at it as one of the causative factors of antepartum hemorrhage or APH. Now, first is maternal age, less than 35 years. This is, a younger woman. These are risk factors. So we are talking about risk factors, stroke etiology. So it doesn't mean that when you are younger than 35 years every day you will be presenting with placental Praevia, but it is a risk factor to mean that it attributes to that occurrences. Multiparity, a woman who has been pregnant or maybe given birth more than once, right? So that tendency will also give this woman the risk factor of maybe prone to placental Praevia. Short intervals between pregnancy. You realize that the mother is pregnant today, like let's say today is on 14th of August, and again after delivering the next year, immediately after 3 months or maybe 6 months, or maybe let's say just within the same year, the hand maybe after 9 months, which is a custom, again is present. So that short interval duration between one pregnancy to another can also attribute to what we refer to as the placental Praevia. Previous curettage or cesarean delivery can as well result, and I'm sure that you know what are the curettage or the cesarean delivery, that is surgical route of delivery. We also have previous placental previa. If this woman has got an history of having or experience a placental previa before or in previous pregnancy. Another one, recurrent abortion. If your tendency of abortion that is directly, however, what kind of abortion can be even be threatened, but still, with that can as well attenuate as a risk factors for placental previa. Infertility treatment like the use of CC, they can as well, because those are chemical agent, just like any other, even family planning can attribute to the same. Then smoking and cocaine use, those are drug uses that we are all familiar with. The same thing, let's proceed and see. Now we have classification of placental previa. Nataka sasa uelewe hivi. I just want you to understand. Because the placentation does not take place to the right place, it takes place at the lower ground next to the cervix, the internal opening of the cervix. So it means that actually that is not the intended place. So when the cervix is completely covered by the placenta, to mean it has directly or perpendicularly to the cervix opening, that is what we call the complete previa. But when it is partially, we can now have incomplete previa, or what we call the marginal previa. So we can have complete placental previa or the marginal previa. So when you say complete previa, that is a complete coverage of the cervical OS by the placenta. So if the leading edge of the placenta is less than 2 centimeters of the internal OS, so it means that it does not cover fully the internal OS. It's going to be, it is considered to be marginal previa. If the os, the opening of the cervix, is not covered completely, you're going to have that marginal previa. So that is that. Now those are the subtypes. From your hand you are able to see them. From your hand you can see we have type 1. It's not even close to the cervix, but it has the lower hand of the uterus. And then we have placental previa type 2, then type 3, then type 4, which is completely. And we are going to see how this one, what they come with. Clinical presentation of placental previa. That is where we are. Now, before I display that, I want us to contribute. What do you think that a mother who is having placental previa can present like? Anybody, what do you think will be some features of a mother who has got placental previa?
She can present with vaginal bleeding.
Vaginal bleeding, that is definitely, that was the very first thing that you had to say, I'm very sure. Any other person? Yeah, be it painless, as much as the hallmark there, what we are interested in is the bleeding, right? Yeah. Claire Wamalwa, what do you have to say?
The bleeding is bright red.
Yeah, it's scarlet or bright red, is not dull. Okay, that is one. And two, the second one. The third one, who has got another idea? Or what are clinical features we are expecting? No ideas, eh? Okay. So that is that. In front of you, you'll see I've shown you, we have the first clinical presentation. The bright red, the way Kalaya Omalo said, there will be presence of painless, bright red, vaginal bleeding, but it can stop spontaneously. And then it can start again when the labor is now present. Then the second clinical presentation is the vaginal bleeding will always be there in the third trimester, or maybe at the end of the second trimester. We'll have soft non-tender uterus to mean it is painless. Non-tender to mean that when you do the palpations, you realize that there is no any guarding from the mother. You know, when you do, every day when you do examination on the abdominal, and then you are in palpations, and you know, you have to monitor the fascial and the guarding sequence of the woman. Okay, is like, yeah, showing some guarding response, there is tenderness. Then there will be no fetal distress at most, but at more at the third hand, you know, this one cannot be associated with other condition like abruptia, placenta, so you never know. So at that mount, not always, this one now will help to rule out. When it is associated with abruptia placenta, there will be fetal distress. But with only placental previa, there is no fetal distress. There will also be sign of shock in case of profuse hemorrhage. Profuse hemorrhage is that severe bleeding, and it is characterized by shock because we know that shock is a clinical state where now the mother undergoes what we call hypoperfusion. Decrease in the circulation amount of blood, and therefore there are some normal features like at most they'll end up being cold. Yeah, some will be unconscious due to oxygen supply, right? And several other, some can even start to shiver. So it depends. So that is that. Clinical presentation of Praevia, that is that. Now let us check on the diagnosis. First of all, it is a clinical diagnosis, and when you say clinical diagnosis, what I need you to understand is that history and examination plays a vital role. History and examination is a key chief for this. And then we'll have speculum examination. Speculum examination is more or less, but technically, vaginal examination in a way. So we can use speculum examination. You know, we have two types of speculum examination. You can use either of them, right? And then you can establish your diagnosis. Another idea is that you can use this the same. Now that golden one is, you can have digital one and the other one. Then we have transvaginal ultrasound. Who can tell me what is transvaginal ultrasound? Who can tell me what do you understand by transvaginal ultrasound? Because that is the gold standard diagnosis. What do you understand by the word transvaginal ultrasound? Okay, we normally have aperture of ultrasound, doing the ultrasound. It depends. We have transabdominal ultrasound, we have the transvaginal ultrasound. So the transabdominal ultrasound, normally you expect the ultrasound itself being attached to the skin of the abdomen, then we monitor. We can use that one to monitor the heart rate, the fetal heart rate, or blah, blah, blah. But now the transvaginal, we use something like transiduce. We insert it inside the vagina. And then now, the ultrasound image, we can see it on the screen, is directly from the vagina. So that is what we call the transvaginal ultrasound. The transiduce is inserted inside the vagina next to the cervix, then we monitor using that mechanism. So it has got some imaging scope that it attributes to the screen so that you can view, but it is inserted, the basis behind it just inserted inside the vagina. So that is that. Now we also have lab work, and I'm very sure you know what is lab work. So we have the complete blood count, coagulation profile. In coagulation profile, you are going to check INR. You can check what we call we have the prothrombin time, PT and PTT. So I know you know what is prothrombin time. The other one, thromboplastin time, and the last one, which you call international normalizing ratio. And you really need to know the range. Like for the prothrombin time, supposed to run from around 11 to 13.5. Some will give you from 11 to 14 seconds. So these are just cascade. Like coagulation profile, it is done to know the ability of the mother or blood to clot, formation of the thrombus, or what we call the clot, coagulation, right? So we know the normal ranges. So when you see maybe it is taking more seconds than normal ranges, then the coagulation profile is poor. So that is what we use. We can use prothrombin time index, we can use the PTT, we can use the INR, international normalizing ratio. And then we can also check on the rhesus factor compatibility test to rule out some probable condition as a result of rhesus factor, the antibody antigen reactions. And then this one is called magnetic resonance imaging. This one is just but a radiographic technique, and I'm sure you know it will help to identify placenta accreta, one of the placental condition as well. So most important, MRI is used when we attribute to fluid. You know, percentage of placenta is made of blood and not blood. The blood content of fluidic content. So that is why MRI can also display the image, because it has to have some resonance in it. So the magnetic resonance is what now will give us images, and then we'll identify whether it is placental Praevia or placental accreta. Now, management approach. In the management approach, you see, first of all, what you need to do is resuscitation. This is what we call the supportive management. Every day, but it depends with the level of management you're offering. We can have management based on when you're working in the dispensary, when you're working in a health center, when you're working level 4 referral, or level 5 and level 6 referral, or maybe sub-county level 4. So whatever you have, but the first thing is ABC. You check on the airway. You can check airway simply by calling the patient, attribute whether ana respond na sauti, whether is breathing. You can confirm that one. That is now B. And B, you can check by putting your finger on the nose and see if there is airflow. You'll feel like he or she is blowing your, the woman, she is going to blow your finger. You feel some hair masses passing, that is breathing. You can also listen on the tracheal sounds, the brachial sounds, or the brachial breaths, and you'll know when the respiration, the breathing is there. Then circulation, you can see on the perfusion, confirm by presence of cyanosis, that is circulation is poor. Check on the eye, the peripheral filling rate, clamp by pressing on the tip of the finger, see how the peripheral refill is happening. That is ABC. Then you can resuscitate in case there is insufficiency or circulation. When you say I'm dynamically unstable, to mean circulation is not proper, you can start by resuscitation. One, you will give this oxygen if airway is clogged, or maybe you will clear the air, whatever clogs the airway, so that the patient must be stable and the vital must be stable. For resuscitation with the fluid, you can use wide bore cannulation. And when I talk about cannulation, I know you know the cannulas. The cannulas, if I had a sample, I know I have a sample in my house, but I'll take time to find it. But I know you can go and check in internet what is cannula if you've not, but I'm sure that you have, because you guys are not, most of you are not in first year. So the cannula, they range depending on the size. You can find they are graded on the G from, let's say we have G14 to G26, but mostly in the hospital you'll find up to G24. G14 is actually the largest, at around 240 ml. It's always yellow in color, and the last one, that is G24, is always violet in color. So you need to know them. So when I say wide bore cannulation, you'll be using the wider one, and then you find the vein which is appropriate. Yeah, some can even use the central vein, that is the jugular vein, next to the jugular vein there, and then you can also use the mid-cubital vein on the elbow joint. Yeah, so you need to know the location of this stuff. In the beginning of management approach, again, you can take some sample of blood for grouping and cross-matching. Why? Because this is an hemorrhage. And hemorrhage, the patient is attributed to a quick loss of blood, which can be severe and fatal, and you can end up having maternal fertility. Or what you need to know, why do we take blood for grouping and cross-matching? Because we are expecting anything to do with hemodynamic and stability. Yeah, somebody is asking, can you use gauge 18? Yeah, you can use gauge 18, and also this factor depends. Like the gauge, which one, the one you're using depends with the availability of the gauge. At a point you are in a clinic setup where you don't have resource. So sometimes as a clinician or as a nurse or as a medical doctor, you have to improvise. So you can use 18, right? But remember, if the bleeding is severe, you'll even use 2 veins, I'm telling you, because we need to resuscitate the patient very fast. That is why wide bore cannulation is always recommended. Now we take the blood for grouping and cross-matching so that we can know blood to transfuse in case of we have increase in bleeding and too much bleeding, and therefore we need to transfuse blood. Then we'll have correctly done the grouping and cross-matching, so they will know. Then we'll have IV fluids, and you know them. We can use colloids because this is blood. But if there are no colloids, if there is no blood for transfusion, you can use the normal one. You can use the normal saline as well. Yeah, so that at least the circulation can be profound. It can be profoundly resuscitated, and that is what I'm talking. So procedures management start with this supportive management, not drug, but just physical care. So that is that. Now, management still, we now check on the gestational age, 37 weeks and below. First, you confirm if there is no active bleeding and no evidence of fetal distress, you do what we call expectant management. Who can tell us what is expectant management? Expectant management? Anybody, anywhere? Tell us. Let us get from you. Were Moses, sema kitu.
Okay, it is like you let
Okay, Moses Were, you're there. Any other attribute? Claire Wamalwa, please.
I'm just trying.
Okay.
I was thinking maybe bed rest.
Yeah, you guys are just on the right track, eh? Any other person with another additional idea on this?
I think
Masi Sugoi, Songoi?
expectant management. Expectant management is whereby you watch a mother closely in case of, but you don't treat anything. You just treat when there are symptoms.
Yes, that is what I wanted, yeah? You are monitoring the vitals, you are checking the mother if there is too much bleeding. It's just like you are expecting something. So you're managing an expectation, but you're not doing anything. You confirm whether this patient is faring well, and then you'll accord the necessary management if needed. So it's just like you are bed watching the patient, right? So you can give a duration of expectant management. If at all there is no any expectation positively returning, you can discharge the patient. So that is what we call expectant management. You just have to monitor vitals and any other expectation that you are thinking of, and then that is that. So again, we are having what we call in case of severe and active bleeding. Now that is no expectant management again here. Now we have when we have severe bleeding, active bleeding, or evidence of fetal distress. Who knows what is fetal distress? Fetal distress, please. Okay, you know, when you talk about hypertonic contraction, I want to give you a case where you will definitely gauge yourself and understand what is fetal distress. It can come from many things. As much as there is a force of maybe compression, maybe anything which distract the comfort of the fetus in the uterine and the uterus, you realize that even the oxygen supply will be cut off, so the fetus will end up now start even breathing or inhaling the meconium. So those are the factors that can attribute to what we call the fetal distress. It can be due to placental previa, placental pressure, the placental previa, or with what we call abruptio placenta. Yeah, can result to what we call the fetal distress. Most commonly, you'll realize that there is anything to interfere with the circulation of the placenta, in the umbilical cord. So resulting to definitely struggling of the fetus, sometimes can even result to the fetal death. So that is what we call the fetal distress. And most the patient who present with what we call the hypertonic contractions, hypertonic contraction, or what we call tetanic contraction, they always show off with signs of fetal distress as well. So that is what we refer to as the fetal distress. So we have, in case of such evidence of fetal distress due to active bleeding or blah blah blah, you start stabilizing the patient. You find out you can stabilize from bleeding, you stop the bleeding, yeah, and then you offer emergency cesarean delivery immediately. That is the management of that. That is for gestation of 37 weeks and below. Gestation age of 37 weeks and above, that sign supposed to be above, we do immediate delivery. 37 weeks and above, we do immediate delivery. Now, let's check on the expectant management we were talking about. First of all, we do hospitalization, that is inpatient, you don't discharge. And then after that, you do observation for 48 hours. And under expectant management, if at all the gestational age is below 34 weeks, you'll have to ensure there is lung maturity. So you will induce lung maturity by using betamethasone as one of the corticosteroids. Recommendable, that is, you will need to go and check on the dose, but the dose also refer to the country you're working in, the kind of the race you are dealing with, yeah, not the same. So that is why when you are practicing on your internship or wherever, practicals or clinicals, you realize that when you go to this hospital, the dose at times vary, but there's some dose, like for oxytocins, they have a limited or bounded range, so you cannot tamper with. So you'll know corticosteroid is used to stabilize or maybe mature the lungs of the fetus. Gestational age between 34 to 37 weeks, delivery is likely within 7 days. So you also use corticosteroid just to 6 milligrams. Dexamethasone you can use 6 milligrams, but it's not recommendable for you to have a fixed unit of measurement. It depends. Sometimes you will use your 6 milligram, then somebody will rebuke you on that. So on that is that. So if it is, we have mild uterine contractions. When we have mild uterine contraction, when they are present, we can use what we call tocolysis. And what is tocolysis, or what is tocolytic? Who can tell us what is tocolytic? Okay, tocolytic, these are just, they reduce the tendency of premature delivery. They reduce the labor. Yeah, they're like just a pacemaker. Tocolytic, they tend to stop the labor so that we don't have premature delivery. So like tocolytic agent, magnesium sulfate normally use. It is always, it's performed, especially if the fetus is extremely premature, so that the mother does not deliver in a premature state of fetus. I mean, before the gestational age or the term is achieved. So the tocolytic, they just abort the process of, labor. That is what you need to know. Route of delivery. The recommended route of delivery, when we talk about cesarean section, we use what we call the lower segment cesarean delivery, or what we call fenetrian. You go and check on that transverse sectioning that is done on the lower segment cesarean delivery. That is almost always preferred, ideally scheduled between 36 to 37 weeks gestation. And then we can also induce the labor or vaginal delivery in the operating room if the mother is hemodynamically stable, to mean pressure yake iko sawa, circulation yake pia iko sawa. You check on the fetal cardiac status, it's very reassuring, to mean you can use the fundoscopy or whatever, any other, the Doppler sound, and then you can listen, and then you'll denote whether the heart rates are normal. That is when you'll know if the fetal cardiac status is reassuring. Again, check on the placental lies, where it is it Praevia or 2 centimeter complete or marginal placental Praevia? Yeah, and so that one you can use ultrasonogram to denote. If that is possible and everything is okay, abdominally stable, fetal cardiac is very assuring, you can now induce the labor using oxytocin. And then vaginal delivery is okay to be performed at that state. Maternal complications. So let us check on the complication that comes from this. Complication number 1, we have hemorrhage. That is, we know, bleeding, and somebody can bleed and rebleed until she dies. Another complication that can come from this is high rates of blood transfusion. Too much blood transfusion, so you can end up even lacking blood to transfuse, and that is also death automatically. And when we have a condition which is at emergency state, like now of a bleeding, or maybe the hemorrhage is so severe, and then the blood is not there, you can even be confused in a way. So even cross-matching can be a problem. You cannot deduce, and therefore you can even transfer blood which is not properly screened. Placental abruption can also be one of the maternal complications. Placenta can detach prematurely from the wall of the uterine. We can also have preterm delivery by the same, that is, placental Praevia can result to preterm delivery for the mothers. We can also yes, clinic. What is your name? You've given your name to be clinical medicine. We know you are in clinic. What is your name? He's asking which medicine is used to induce labor. Who can answer our friend? Which medicine is used to induce the labor? Citrus. Yeah, Bramwell.
Maybe a trial. I think we should use oxytocin hormone.
Yeah.
Or we can also do amniotony.
Yeah, we can do amniotony or oxytocin hormone. And we have other inducers. You can go and take when you're alone. Apart from oxytocin, we have other synthetic, which are just attributing the same, but they are drugs. So the commonly used is oxytocin, misoprostol. But remember, when you say misoprostol, sometimes it comes with adverse effect, right? So misoprostol, okay, it results to, because it has got prostaglandin analog in it, can result to severe contraction, and whatever which can cause contraction can attribute to that. But oxytocin is the best. It has prostaglandin analog in the misoprostol. The way Weria said, has got prostaglandins analog. So it has the mechanical, the structure of misoprostol is merely prostaglandins, so it's the same. So the entire thing, what I'm trying to say, that is always done as a loading dose, but oxytocin is the most used, the one which is very, very used. So let's proceed. We also have, apart from we have preterm delivery, we also have increased incidence of postpartum endometriosis and the endometritis. Postpartum endometritis is just because of infection due to that bleeding and exposed wound. Due to that, we can have what we call postpartum endometritis. Now, this is infection on the endometrium layer of the uterus. Hello? Somebody speak?
I think your question for induction,
Yes.
then we use the treatment for augmentation.
Yes. Okay, mute yourself. I want to. Okay, you see, induction and augmentation. To augment is just to complement the process of labor. Then to induce is to start. Those are two things that our friend by the name clinical medicine was trying to tell you guys. Now let's proceed. Then we'll have a platform of, we want to cut the duration short because this video is going to be shared. So we are going to have a platform after closing the YouTube video. We are going to have a class of interactive arguments and discussion. So let's proceed. Now, I've said most bacterial infection due to bleeding and that exposure can result to what we call postpartum endometritis. So that is just infection of the endometrium, resulting to inflammation reaction on those regions. Mortality rate of 2 to 3%. Then this is the great majority of which is related to uterine bleeding and the complication of disseminated intravascular coagulation. That is, you realize that we have clot or thrombus in the blood vessels. Fetal complication, that was maternal complication. Fetal complication, or what we call fetal complication. Clinical medicine, we are going to discuss that one later. This video is going to YouTube, so we have to pace with the time, finish this coverage, then we are going to check on that later. So fetal complication, or what we have as the sudden infant death syndrome. First of all, we have congenital malformations. And example of congenital malformation ni kama gani? Who can tell us congenital malformations?
So you have microcephaly,
Mm-hmm.
or
Yeah.
microcephaly.
Mm-hmm. Yeah, I've gotten you. So can you explain each of them? Anencephaly, absence of something, microcephaly, small something. So tell us, somebody doesn't know what is microcephaly. As a congenital malformation, what is microcephaly according to you?
Microcephaly is whereby the newborn has a small head,
Yeah.
normal.
Mm-hmm.
Hydrocephalus,
Mm-hmm.
where it just has a bigger head than normal.
Mm-hmm.
For the other one,
Mm-hmm.
anencephaly,
Mm-hmm.
where the baby rat, the cerebrum, the upper part of the head.
Correct. The some portion of brain is missing. That is anencephaly. You're right. Yeah, we have other congenital malformation like cardiac defects. I know you know them. The dextrocardia. I know you know the dextrocardia. The heart is located different. Instead of it being on the left side, it's on the right side. Yeah. So such like we have the spina bifida. Blah blah blah. Thank you, clinical medicine, for giving us that. We also check on the fetal intrauterine growth retardation, because we know that depending with gestation age, we know we have a certain range of growth. So if we have retardation, we also note. So that is one of the fetal complication again. Fetal anemia and rhesus factor isoimmunization is another one. Abnormal fetal presentation. I know you know types of fetal presentation. You know the typical one that we expect. So we can have abnormal fetal presentation like breech presentation, the shoulder presentation, low birth weight, that is in Kenya, birth weight ranging lower than 2,500 grams, neonatal respiratory distress syndrome, or what we call hyaline membrane disease. And you know how it manifests. It manifests with rapid breathing, orthopnea, tachypnea, tachycardia, all those ones, right? Can also present jaundice as one of the complications of the placental previa. And I know you know what is jaundice, the yellowing of the sclera of the skin and the mucosa pigment. Can result to what we call admission in neonatal intensive care unit, where we can have incubators and some care is provided to stabilize the baby. It can also cause longer hospital stay, can increase the risk for infant neurodevelopment delay and sudden infant death syndrome, or what we call the SIDS. And finally, it can cause neonatal mortality rate. And that range there is as per the United Statistics. So the next class we are going to have on abruptio placenta, and I'll tell you to know on what is that class. Already we have covered 40 minutes, which is not that bad. Thank you so much for being present today, and then we attribute, I know you know I'm Uma. Yeah, this is courtesy of Medical Students Arena. Thank you.